In the CARD trial, patients who had metastatic castration-resistant prostate cancer that had progressed on one androgen receptor-targeted agent and docetaxel chemotherapy were randomized to receive treatment with the other androgen receptor-directed therapy, or cabazitaxel, at its standard dose, 25 milligrams per meter squared, plus Neulasta. Patients were followed for radiographic progression and overall survival in this trial, and we found that patients actually had prolonged progression-free survival as well as overall survival in the CARD trial. Importantly, the CTCAE graded events, which talk to us about the toxicity of the agents, suggested that the chemotherapy did not have any side effects that are really outside of its traditionally considered side effect profile. And there were actually more grade 5 adverse events leading to death in the patient arm, the patients that were treated with the AR-targeted therapy. So fewer grade 5 events in those patients receiving chemotherapy. Importantly also, these patients had a better pain response when they were treated with chemotherapy, probably because of better disease control. And so we saw that this was really what I consider a practice-changing study, in that it defined for us a path forward in the third-line setting in metastatic CRPC, where we had not actually had trials that show us what happens to patients who have already received first and second-line treatments for mCRPC. These patients seem to tolerate the treatment actually quite well, as I said, both in terms of CTCAE and in patient-reported outcomes, with their overall quality of life also being reported to be better when they were treated with cabazitaxel as compared to the androgen receptor-directed therapies at the 3-month assessment by the overall quality of life measure, the FACT-P. So the drug was actually quite well tolerated and ultimately improved survival in this heavily pretreated third-line metastatic castration-resistant prostate cancer population. When I think about using a second AR-targeted agent after exposure to and progression on a prior AR-targeted agent in the metastatic CRPC setting, I really talk to patients about the inadequacy of that therapy, that sequencing, and my expectation that the treatment is probably not going to help them. This has been demonstrated certainly in the control arm of the CARD trial, but it has also been demonstrated in other settings. For example, in the PROfound phase 3 trial that looked at men with metastatic CRPC who had DNA repair defects, men were randomized to treatment with olaparib or the other AR-targeted agent. And this was in patients who had already progressed on chemotherapy and an initial AR-targeted agent. We saw that the radiographic progression-free survival of that control arm, the second AR-targeted agent, was about 3.5 months, which is very, very similar to what we saw in the CARD trial, which was about 2.5 months or so. And so we consistently are seeing in patients who have already progressed on an initial AR-targeted agent, whether they progressed within 12 months, like they did in the CARD trial, or whether they simply progressed at any time point, which they did in the PROfound trial, that the expected time to controlling disease and preventing radiographic progression is really short. And the reason that it's probably around the 3-month time point is because that is when they were doing the radiographic assessment. So most of these patients are progressing on the first or the second radiographic assessment, really suggesting that we're not controlling the disease growth. So there are patients, few patients, who may respond to a second AR-targeted agent. And usually I think about use of enzalutamide after abiraterone being potentially a little bit more effective. But this is not my first choice and is something that I highly recommend patients consider not doing because we do know that the mechanisms of resistance are quite similar. And especially in settings where we have an aggressive cancer and we need to control the disease, this is not expected to really do that and actually could waste time for patients, leading to decline in functional status and potentially closing the door for them to get something like chemotherapy, which may actually prolong their life, but has to be given in patients who are well enough to tolerate it.